Hello, everyone, and thank you for inviting me here at the Atlantic. The Society for Women's Health Research has one mission, which is to correct imbalances in care for women and improve health for women through science, policy, and education. And when we talk about policies, one that we focus quite a bit about is coverage and access policy. That's a very short phrase for a lot of content and a lot of nuance. So, Steve, when the president announced his proposals to cut drug prices, there were many, many nuanced health policy conversations that began. From what you heard, what types of policies do you think will really drop drug prices for patients, and which proposals could have unintended consequences?
Well, thanks, Amy, and it's great to be with you this morning. I want to make clear at the outset that, as I'm speaking on behalf of the industry, that we're not here to defend the status quo. We think the system is not always structured in the best interest of patients, and we think change is necessary. And the real question is, what's the right kind of change? In summary, I think there are proposals in the president's suite of 50 ideas that have great potential to lower costs not only for the system, but for patients. And there's some ideas that could have unintended consequences. And as the Secretary and the Commissioner have talked about, I think everyone needs to come to the table with constructive ideas on how to evolve those proposals so that they continue to strive to improve patient care. We're very heartened that the proposals are holistic in nature, and a few of the ideas that we think have the greatest potential. One is looking at misaligned incentives in the supply chain and facilitating more direct patient support in terms of rebates and discounts making their way to patients at the point of sale. As been mentioned by previous speakers, we have a situation today where drug spending and drug prices are actually growing below the rate of overall inflation, not medical inflation, but prices are up 1.9%. Overall spending is up 0.6% last year. Rebates and discounts have grown to more than $130 billion last year. And you would assume if drug spending is going down and rebates and discounts are going up, that patient out-of-pocket spending would be going down. And unfortunately, it's not. Deductibles have grown 300% since 2006. And too often, patients in the deductible phase or facing coinsurance are paying the full list price of the medicine, so they're really not benefiting from the fruits of the marketplace negotiations that take place between our members and plans. So the system as a whole is working to constrain costs, but it's not really working to the benefit of patients. Insulin was talked about on an earlier panel. My son has type 1 diabetes. I'm pretty close to the insulin market, and just to walk through how this gross to net bubble has really distorted the marketplace. A typical patient in the deductible phase goes to buy their insulin, say it's $400 a month. It's one of the most competitive classes of medicine, so the rebates and discounts are 50 or 60% or more. So the patient in the deductible pays full list price, say $400. The health plan is pocketing a $200+ rebate, and our members, who retain about 60 cents of the list price of a medicine, are retaining about $88. This gross to net bubble has really distorted the marketplace and is increasing costs for patients. Other ideas that I think could have impact, we've been quite critical of the convoluted list price, rebate, and discount model. We think we need to move towards more outcomes-based models where we're actually paying for medicine based on the outcome achieved by the patient. We think that's a much more rational discussion, and there are policy barriers that stand in the way of more of those arrangements taking shape. So, well, how could that save money? I'll give you a couple of examples. CAR-T, which is a miraculous medicine, we know that not all patients respond to it. 20 or 30% of patients will respond. Our companies are willing to put their money where their mouth is and be reimbursed when the patient responds and not reimbursed when patients don't. Or if you have a medicine that works really well in lung cancer, but the data is less mature for stomach cancer, it doesn't make a lot of sense to have one price, one drug. So having differential reimbursement, again, based on the outcome achieved by the patient. 340B reform, very well-intentioned program. that should remain, but there's mounting evidence to suggest that it's actually increasing costs for patients. It's fueling consolidation in the marketplace. It's driving site of service change from less expensive to more expensive settings. It's impacting prescribing behaviors. So we think that has become a distortion in the marketplace. The president's talked about free riding and other countries stealing industry's IP or taking other steps that undervalue innovation. We think really looking at opportunities, whether it's enforcing existing trade agreements like the Korea Free Trade Agreement or NAFTA or other opportunities to ensure that other countries are paying their fair share and not inadvertently having the U.S. subsidize the world's R&D. So those are some of the ideas in the president's proposals that we think could make a big difference. In terms of policies that we have some concerns about, there's been a lot of discussion about the idea of moving medicines from Part B to Part D. You can understand the intuitive appeal. Part D does have this component of marketplace negotiation, which produces 30 to 40% rebates and discounts on average. But there are lots of complexities and differences between the two programs. Part B is actually underappreciated in our view. It's a program where it still represents about 3% of overall Medicare spending. There is a competitive dynamic within B in the sense that ASP reflects rebates and discounts in both commercial and public payers. Patients typically have supplemental insurance, so they're protected from out-of-pocket costs. So the program today facilitates access, and patient out-of-pocket spending for most patients is managed. If you look at Part D, on the other hand, you have a situation where patients could face 30 to 40% coinsurance. Plans might not cover a medicine that a cancer patient needs. So my point is that there are really a lot of potential unintended consequences if we don't approach that issue very carefully. And the same thing is true for Part D and changes, for example, to the 6 protected classes. Those classes were chosen for a reason. These are the most vulnerable patients. Not all medicines are interchangeable. So we have to approach those discussions with care.
I think I speak on behalf of everyone in this room that we have job security trying to untangle coverage and access policy alone. That doesn't even get to regulatory policy.
Absolutely.
When thinking about this administration, I've been very excited about some of the things we've seen from the Food and Drug Administration. That FDA has been thinking about great ideas for some time, and we're seeing many of them come forward. So at the Society for Women's Health Research, we want to see regulatory modernization that looks at the patient experience, looks at areas of unmet need in women's health, or looks at treating the direct condition rather than the symptoms of the condition. When you think about what you've seen at this FDA, what have you liked, and what kind of modernizations would you like to see?
Well, I thought the commissioner did a very nice job this morning outlining, what we see as the core focus area. When an application shows up at the agency does a very good job. I mean, it's a very efficient review process. But as long as it takes 10 years and $2+ billion to develop a medicine, we're not going to get a handle on costs. So looking at how we can reduce development cycles, as the commissioner spoke to this morning, we think is key. And I think there's a couple of ideas in that area that the commissioner is focused on that we think can make a real difference. One is better leveraging of real-world evidence. We're at this great tipping point where not only are we seeing incredible innovation on the science side, but in terms of data aggregation, machine learning, and computer sciences. So increasingly, I think we'll be able to move to a situation where we'll be able to capture real-world information in health claims at an individual level in a way that the FDA can lever not only for post-market studies, but ultimately to shorten the development cycle so that companies can use that information working with the FDA on new indications, for example. Another idea that the commissioner spoke to is adaptive clinical trial designs and leveraging, again, computational advances, whether it's Bayesian statistics or other models that could preclude the need for animal studies or other more expensive, RCT-based efforts. So we think, the commissioner is focused in the right area in terms of lowering those development cycles and really trying to lever scientific gains on the computer sciences side.
And I think it's worth mentioning that on the diagnostics and device side of FDA, there's a lot of creativity in exactly those areas.
Absolutely.
Yeah.
Yeah.
Well, thank you for your time, Steve, and thank you again.
Thanks, Amy.